Good morning. It's a pleasure for me to show the data of our SORAML trial in acute myeloid leukemia. In addition to standard treatment, I will show a second later, we added sorafenib in a randomized trial. Sorafenib is an inhibitor of several proteins in the cell and thus increasing the killing by standard treatment. Sorafenib is approved in renal cancer, and in several in vitro studies it did show activity in acute myeloid leukemic cells. Based on these data, we added sorafenib in a randomized trial, either that patients received the standard treatment, daunorubicin RRC, 2 cycles, and then high-dose RRC afterwards. In patients receiving sorafenib, sorafenib was given between the treatment cycles, in addition for 12 months later for maintenance therapy. Patient populations were those with newly diagnosed AML, and in the AML field, younger means age below the age of 60, in good performance status and adequate renal and liver function. Several patients were excluded having significant heart disease, acute promyelocytic leukemia, uncontrolled hypertension, because this drug can increase blood pressure, recent trauma or operation because it can increase bleeding, is blocking VEGF, and those patients having pre-treatment of AML. I would like to show you first the event-free survival. That means all patients which were without disease at different time points. And as you can see, the 3-year event-free survival was increasing from 22 to 40%. And when you are looking for the median event-free survival, that means the median where 50% of patients were surviving event-free, it was increasing from 9 months to 21 months. That means an increase of a year of event-free survival. Looking at patients who came into complete remission and looking for relapse-free survival, you can see that it was increasing the 3-year relapse-free survival from 38 to 56%. And most interestingly, the median relapse-free survival, placebo versus sorafenib, was 23 months in the placebo arm, and those patients receiving sorafenib are at 60% and not reaching the 50% margin. That means overall that less patients have had a relapse, not needed reinduction therapy, and not in the need for blood stem cell transplantation for relapse. The trial was powered to show a 20% difference. It was not powered to show overall survival, but it was expected that because we have salvage therapies in place in those patients relapsing, at 3 years it's a 7% difference in overall survival, as you can see here, but that's not statistically significant, and the median placebo versus sorafenib is not reached yet. We made a decision to prolong the observation period for these patients. At Sunday, the first author, Christoph Röhlich, will show the data for molecular subgroups. And as you can imagine, because only 130 patients were in each arm, that there was no difference in genetic subgroups, no difference in FLT3 mutated patients, again because the numbers were too low. Overall, this is a significant development and relevant because we have a prolongation of event and relapse-free survival. We have a high level of evidence about the efficacy of sorafenib in young AML patients, and this is the first randomized trial showing the efficacy of kinase inhibitors in AML after more than 20 years of attempts to improve event and relapse-free survival in these patients. We would like to see a validation in larger trials, looking also for genetic subgroups, and we are currently looking for other genetic markers which might show which patients are benefiting from this compound. Overall, because the patent situation for Sorafenib is running out, it shows also a problem if a drug company is not interested to get a label and approval for a new compound. Sorafenib is not available for AML patients despite this benefit. The costs are about 60,000 euro per patient, and therefore we need stronger lobbying that the same for M3 patients with arsenic trioxide, where we did show in a randomized trial the benefits for arsenic trioxide ATRA, but it's no label on it, and the reimbursement in several European countries is also very difficult to achieve, and therefore new drugs having approval can give into a patient, but those old drugs which show benefits are difficult to get reimbursement, and it's a hard work for us to come forward in this field. Thank you.